Okay.
All right. Hi, everyone. My name is Sara Semal. I am the Senior Director of Wellness at Occidental College, and I am here with Dr. Kim Schreiner. She is an infectious disease specialist, an expert in her field, working at Huntington Hospital, and consulting with us on the work that we're doing at Oxy in terms of preparing for in-person residents this fall and hopefully in-person classes and residents next spring. We have a health and safety committee, a number of fall implementation teams, and a COVID operations group that are working hard to create an environment at Oxy where we can be safe and have safe living and working situations for all of our community. So Kim is here with us today. Dr. Schreiner is here with us today to share a little bit about COVID and expand our understanding of the disease and how it's affecting our population. Kim?
Thank you very much, Sara. Well, I'm delighted to be here. Good evening for some of you on the East Coast or around the world, and good afternoon for those of us on the West Coast. As Sara said, I'm here to kind of give you a review of what we know at this very moment about the COVID pandemic and some of the challenges that face us going forward with this disease. So as I was talking earlier to one of the hosts, you know, this disease hit us very quickly, and so I think a lot of us are still trying to sort things out. Every day that goes by, we learn something more about a coronavirus, how to test for it, how to potentially treat it, and most importantly, how to prevent future infections. So I hope this answers some of your questions, and I'd be happy at the end to go ahead and ask some other questions. I don't know if Sara told you this, but I attended Occidental College between 1976 and 1980. And at the time, Oxy had a research vessel called the RV Van Tuna. I spent many hours sorting fish with fish scales in my hair, chugging up and down the West Coast, studying the impact of Southern California Edison on our marine environment. John Stevens was my professor at the time. And though I went on to become a medical doctor, those very formative years were very important in my career. And I really would like to thank Occidental for providing me with such a great opportunity and a great education, and especially to Dr. Stevens, who continues to be an inspiration. So it's a great school. So let's talk a little bit about the current situation as of today. Well, the first is why are we doing this virtually? Well, the current situation is that unfortunately in the United States, we continue to have a very serious outbreak of coronavirus, and in many states, including California and especially LA County, we are having a very large upsurge in the activity of disease. And when that happens, it makes the risk of transmission in any kind of environment, especially a college, particularly dangerous. This is a highly infectious pathogen. It's a brand new pathogen. None of us have any immunity to it. We don't have very good therapy, and we still are kind of working out the best way to test for coronavirus. And so we have a difficult time trying to survey what's happening with the disease in the community. And so for that very reason, it was the decision of the trustees and the administration at Occidental to take the safest route for our students and for our staff and to do this virtually, which has been the decision of almost all the universities in high-risk areas, especially California. So the reason, you know, this is a very infectious pathogen. There has been very wide and rapid global spread, really over about 5 months or so. No country on the planet, with the exception of Antarctica, and that's not really a country, but are immune to this pandemic. There's a very high density of disease through many countries, especially the United States right now. It causes very serious illness and frequently death. It is transmitted it's transmitted largely through casual human interaction and behaviors, which makes it very dangerous and very infectious. No one has any immunity. Again, there's no robust therapies, and as yet we don't have a vaccine, but I will discuss that a little bit as we move forward because those things are changing. So as of this day today, we've had 19,947,467 confirmed cases of COVID-19 throughout the world. Almost 750,000 people have died from this disease. Unfortunately, the United States is one of the leading countries with the number of cases. So we passed a very ignominious marker yesterday at 5 million cases confirmed. There's probably 10 times that number of cases in the United States. We just don't have very good testing to identify that. And unfortunately, we've lost over 160,000 people to COVID-19. Los Angeles County is a very large county, and it has been a very serious area for disease. As of today, there have been 208,000 confirmed cases of COVID with almost 5,000 deaths. So it is very densely distributed throughout LA County and of great concern. Some parts of Southern California, in particular Imperial County, have been particularly hard hit by this disease. And so it is a very common disease in the community. The United States continues to have a rise in the number of cases. Some of that is due to the ability to test for the disease, but the bottom line is that we have more disease because the disease is spreading. There are no areas that are immune to this. It's beginning to emerge quite scarily, if you will, in rural communities. And because of our testing problems, we really have not been able to get this under control as quickly as the European Union has. They have largely centralized healthcare systems, and they've been fairly aggressive in lockdown and shelter-in-place mandates. You know, the United States, we've been trying to be a little bit more liberal about some of those things, and I think unfortunately it's allowed the virus to take off, and we're in this situation now where we have a very, very high burden of disease. These are some statistics. The percent positive test is an indication of kind of a snapshot of where the virus is each day. And before you begin to consider opening up societies, you want the percent positive tests to drop below about 5%. And you can see in the United States, we're still very high at 8.2%. That number has plateaued a little tiny bit, but it's likely to go up again if we have problems with controlling the disease through our mitigation protocols. So this is not our first pandemic. Pandemics have been part of human history since the beginning of time. And there's very good documentation of prehistoric plagues from skeletal remains in prehistoric China and so forth. Some very famous plagues in the early literature. Oxy is a liberal arts college, and all of us had to read some very early literature, even if you were a bio major. The plague of Athens, a very famous plague that occurred in 430 BC. It's not known what that pathogen was. It may have been Salmonella typhi. It may have been diphtheria. But it took its toll on the Greeks and probably led to allowed the Romans to come in and conquer Greece. The Romans kind of got their comeuppance though with the plague of Galen, which occurred in about 165 AD, and that's thought to have been smallpox. Of course, probably the most famous plague up until the HIV pandemic was the Black Death, bubonic plague that went through Europe, wiped out about 25 to 50% of Europe with the bubonic plague. And really changed a lot of the socioeconomic structure of Europe, leading to the emergence of the Renaissance. There have been many plagues, especially among indigenous people, brought in by the Europeans in North and South America, smallpox being a terrible disease that was ravaged through a lot of the indigenous people, as did measles and then some other hemorrhagic viruses. In the 20th and 21st century now, we also have had some famous pandemics. Of course, the one that we use a lot as an analogy to this one is the 1918-1919 Spanish flu pandemic. That was an H1N1 variant of influenza. It affected about a third of the world's population. It killed about 50 million people worldwide. It was a very, very serious pandemic of which, again, no one had any immunity, although it was a virus that is fairly familiar to human beings, being the influenza virus. Most of us in infectious disease thought we would probably have another pandemic at some point. And indeed, we were very focused on influenza as the likely culprit because we've had a taste of that periodically in 1957, 1968, and of course in 2009 when we had the H1N1 pandemic of influenza. All of those were very serious pandemics, especially the 1918 one, of course, but in the later years we've got some tools to vaccine, certainly for influenza, and also some medication, so they didn't spread quite as rapidly as this one. 1981 was the beginning of the HIV pandemic. I started my career in infectious disease with this pandemic, and I suppose I will retire with another pandemic. The HIV pandemic has a lot of similarities to the coronavirus pandemic, which I'll discuss a little bit, just in terms of the fact that it is a zoonotic infection, and it's had a lot of repercussions in terms of socioeconomic changes and social changes, some of which have been actually for the good. The benefit of the HIV pandemic for the coronavirus pandemic is that many of the medication platforms that are used to design antiviral drugs and perhaps an antiviral vaccine in this situation are already in existence because of our work with HIV. HIV was a devastating 100% lethal disease in the 1980s. It is now a very treatable and perhaps soon to be curable disease, although we still don't have a vaccine. So that is something to remember as we look forward to a vaccine with coronavirus, that vaccines can be a pretty big lift sometimes in terms of effectiveness. We had a little taste of a previous beta coronavirus with the 2002-2003 SARS outbreak. And then of course the Ebola outbreak. We have periodic episodes of Ebola. That was a scary one in 2014 when a large portion of West Africa began to have this outbreak. Thankfully, it didn't spread quite as globally as fast as this virus has. So this was a quote from Dr. Fauci. Anthony Fauci, of course, is the head of NIAID, a really remarkable person who has served many, many presidents and is having a very challenging time right now. But he was asked what was his nightmare scenario, and he basically said, this is it. And the reason why it's a nightmare scenario is because it's a respiratory-borne, brand new pathogen and has a significant degree of illness and mortality. And none of us, not one single human being on this planet, have any immunity to it. So for those reasons, it really is the perfect storm for respiratory pathogens in a pandemic. And that's really why this has been such an important and challenging time. So what is SARS-CoV-2, the virus that causes COVID-19? Well, it's a member of the coronavirus family, and they're called coronaviruses because of these little spikes that occur around the virus if you take an electron micrograph of the virus that makes it look like a crown. It's a very large group of viruses, and it actually has the largest genome of viruses. It affects other animals besides humans, specifically and perhaps most importantly bats, but other mammals can get it as well. Reptiles tend not to be infected with coronavirus. And many of us have had or know coronaviruses because we've had the common cold, upper respiratory infections. Sometimes it can cause lower respiratory infections, including bronchitis and pneumonia, which of course is what we're seeing with this particular variant. But the coronavirus that we're used to are alpha coronaviruses, and that's a common cause of the human common cold. This virus is a beta coronavirus. It is an animal virus that jumped from bats to humans. Because of that, when viruses make a transition from an animal host to a human host, they frequently become more virulent and nastier. And that's exactly what's happened with this particular virus. So it's endemic to many different types of bats and hedgehogs, ironically enough. But the Chinese horseshoe bat is probably the source of this particular virus. And of course, it is very, very nasty. It's highly infectious and causes very serious disease. So coronavirus is not a hoax. It's the real deal. It is a pandemic. There is absolutely no evidence that it was some type of bioterrorist weapon or some sort of laboratory experiment gone wrong. So it's very clearly a zoonotic infection. Very good paper that was published in April in Nature Medicine. About in January, early January, the Chinese released the entire genome of SARS-CoV-2. And this allowed other labs around the world to evaluate it and realize that to study it very carefully. And by doing that, then they were able to go back and identify the animal vectors where this virus came from. It's very clear that what happened was this virus developed a mutation that normally it would not attach to human cells. It was specifically for bats and perhaps for other kinds of animals, but it wasn't that common, and it wasn't common at all in humans. But it developed some type of mutation, either before it infected humans or shortly after it infected humans, that would allow it to attach to the ACE2 receptor sites. These are the receptors in the respiratory epithelium, which are in your nose and in your lungs. This virus just loves to attach there, and that's how it replicates. Again, it's not clear whether this happened before it jumped species or after. There's some evidence that it may have actually happened before, but that's a little more, unclear. A second animal called a pangolin, which looks like this, is a sort of an armadillo type animal, may be an intermediary source for this virus and allows the virus to replicate quickly, so it increases the density of the virus before it's transmitted. Both of bats and pangolins are found in wet markets in China. They're valued for their meat and for the pangolins in particular for their meat and their scales. And it's very clear that this virus probably came from one of the wet markets in Wuhan, and that's how it began to spread. This is the Rhinophilus affinis, which is the Chinese horseshoe bat, which is the likely bat that transmitted it. Bats are a frequent source of viral infections for a couple of reasons. They are mammals, they fly, so they have a very far range, and they're very diverse. There's many bat species on the planet, and they often are the culprit for viral infections, including, of course, Ebola, and perhaps more commonly, rabies. This is just a chart, basically a genetic map that shows the divergence of this genetic material that allowed the virus eventually to develop a mutation, and in the presence of perhaps pangolins where the virus could replicate quickly, and then infected humans in the wet market and took off from there. So why did this SARS outbreak become more serious than the first SARS outbreak? That was also a zoonotic infection that was associated with bats and civet cats. This one, I think, is a function of convergence of sort of a perfect storm. And that happened in the 1980s with HIV. We had the development of global travel at that time. We also had sort of the sexual revolution, the lack of use of barrier contraceptives, and so it allowed HIV to propagate very quickly around the world. For this virus, what happened is that the virus emerged in an area, a very populous city. Wuhan is a very large city in China, and it was very quickly transmitted around that area. And then, of course, people got on airplanes and they flew all over the world. The cruise ships were obviously very notable at the very beginning of this, and they served really as sort of a virus factory, if you will. It's been very clear now that the ventilatory systems in cruise ships and the density of people together in a cruise ship is a perfect storm for this virus. And of course, that was quite famous with the Diamond Princess, that's actually the ship that's in the picture there. So it was a very opportune moment, if you're a virus, to spread around the world because of our frequency of global travel. So how is this virus transmitted? Well, as I've mentioned, it's a highly infectious virus. Most coronaviruses are what we call droplet-borne viruses. These are viruses that are most likely to spread in the presence of mucus. The virus is suspended in small droplets of mucus carried in the nose and in the upper throat. So when you sneeze or you cough, you expectorate and produce a lot of virus that way. And those are called droplet-borne diseases. There are aerosolized diseases like tuberculosis or measles in particular, which have very, very tiny little droplets that can stay suspended in the air for long periods of time. And those tend to be more infectious. Because we thought that this was going to be a sort of a typical coronavirus, although it was a beta coronavirus, most clinicians and epidemiologists thought this probably was going to be a droplet-borne pathogen. As it's turned out, it is largely a droplet-borne pathogen, but it also, under certain circumstances, can become an aerosolized pathogen. And you probably have heard about some of the famous cases of the choir up in Northwest of the United States, where they were practicing when you sing, you expel a lot of mucus, and it also can suspend particles in the air, and about half the people in the choir developed COVID because one individual was infected. You may have heard about some gyms in South Korea where closed ventilation, people working out, breathing very heavily, and the virus spread across greater distances than could be spread just from a mucus droplet. And even the famous Chinese restaurant where one table was sitting that some individuals were infected with COVID, the ventilation system seemed to transmit the virus across the room to another table of non-infected people, and they became infected with COVID. So under certain circumstances, this pathogen can be aerosolized. We also know it can be transmitted by contaminated surfaces. So if you touch a a surface that has mucus on the top of it, and then wipe one of your own mucous membranes, your nose or your mouth, you can potentially inoculate yourself. This is not a very common method of transmission, we think, but it can occur. It's been well documented, and so that's why washing your hands is such an important thing. As time has gone by, we've really learned that the viral load, the amount of virus that you're exposed to at the beginning, and the time of exposure, the amount of time that you're exposed to that amount of virus, are two very, very important factors. If you get a very large load of virus for a long period of time, let's say you're a bus driver and there's lots of people on the bus who have COVID, that's a very high risk exposure, and that's why some of the people on the essential workers are so at risk for developing this disease. Likewise, healthcare workers, we deal with people that are very sick, they have very high viral loads. If you spend a lot of time in a room that has either inadequate ventilation or you don't have appropriate personal protective equipment, then that exposure is a very high risk for developing the disease itself. So those are very important factors, and that's why we want to try to limit the amount of exposure people have. There's not much we can do about the viral load, but certainly limit the amount of time that people spend in closed spaces together, because that's a very high transmission risk. This was a study that was done out of Holland that looked at people running by, breathing heavily. You know, we all worry, well, gee, when you're outside, what's the risk of transmission? The outside is a much safer place than the inside. That's very clear. We do worry a little bit about people that are doing exercises and breathing hard. And indeed, you can measure sort of a jet stream behind them of aerosolized particles. But again, that type of transmission is probably very low. By the time those particles hit the air outside, they're dispersed over a very wide area and are unlikely to transmit the disease to someone else. That said, I wouldn't recommend following closely behind a friend if you're both unmasked while you're running, because that certainly could be a potential transmission if your friend happens to have COVID. As viruses move through the population, one of the things we've been concerned about, and indeed that seems to have happened, is they change their genetic material. These viruses are very imperfect replicators. They make a lot of mistakes when they replicate. Sometimes those mistakes can be advantageous for the virus. Probably the most important part of the virus, and I'll talk about this in a couple minutes, is the spike protein. That's the protein that's expressed on the surface of the coronavirus that it allows it to attach to the human cell. It's kind of like a big giant suction cup that attaches to the human cell, and then it allows it to inject its material into the human cell and turn the cell into a virus factory. Initially, at the beginning of the pandemic, we saw a certain gene for the spike protein called the D614. As things have moved along, we're now seeing a mutation to a G614. It's just a replacement of an amino acid. But that particular mutation seems to have rendered the virus even more infectious. And you can kind of see that if you look back, certainly they had a terrible pandemic in Wuhan, but the pandemic that hit Italy was a magnitude even higher. And so obviously that transition seems to have occurred about that time. And indeed in the United States, the first part of our pandemic may have been a virus that was coming from Asia, but probably we're looking sort of back retrospectively, most of the virus that spread very quickly throughout New York and the East Coast, and now probably is what we're dealing with, is one from Italy. So it's very common for viruses to develop mutations that can be advantageous and increase their infectivity, occasionally increase their virulence. You'll once in a while hear about this R0 value. That's just a mathematical reference to how infective a pathogen is, how likely it is to spread it to another individual. The SARS-CoV-2 seems to be pretty infectious. It's about 2.5 or so, about twice that of influenza. Maybe in certain circumstances, in high viral load, prolonged exposures, it may be even 5 or 6. Viruses like measles are have very high R0 values, about 5. It's very likely measles gets transmitted because that's a true aerosolized virus. But the R0 value has importance in terms of herd immunity. And you've probably heard this before, where if the population, enough of the population develops immunity to a virus, then that decreases the likelihood the virus is going to spread as quickly as it has. Unfortunately, the herd was completely non-immune. None of us had any immunity to this. And because this virus is so infectious and it's traveling so quickly, it's very unlikely that we would reach an element of herd immunity without a massive number of deaths. To achieve herd immunity with this virus that's so easily transmitted, you'd have to about 60 to 70% of the population to have had the virus. And of course, that would lead to an enormous number of deaths. So again, this is a highly infective virus, highly infectious virus that does travel very quickly. And when you're looking at doing opening up of society and so forth, the R0 value is a very helpful one. You want to see an R0 value of less than 1 before you really begin opening society. And we have never achieved that in the United States. So that's why we see so many outbreaks when the bars open or the businesses open. That's a pretty common phenomenon with something this infectious. This was a study out of South Korea that really focused on the importance of household transmission. And I think that really that is the major site of where most diseases are, most of SARS-CoV-2 is passed. I've taken care of now probably 50 to 100 patients with COVID-19. The vast majority of them, I would say 99% of them, knew where they contracted it. And of those patients, the vast majority of them got it at home with their family members. And this was a nice sort of evidence-based study that was done in South Korea that looked at about 60,000 contacts of about 6,000 patients. And it showed that most of the patients acquired the disease in their own homes. They also, more importantly, showed that though little kids, tiny kids, less than 5 years old, were less likely to spread the disease, children that were attending school or young adults were very efficient spreaders of the disease, though they may not have been very symptomatic. And this has been supported by other studies that have been done in China, France, and Hong Kong. So it's a very common thing to see this passed throughout families and at home, but the workplace, of course, is also an important area. So what are the risk factors for transmission? Well, the first is the situation. If you encounter an individual who's infected, especially a family member, congregate living situations are the riskiest arrangement, and humans are social animals. Most of us, many of us, live in congregate living situations with our families or our spouses. Dormitories are a great example of congregate living situations, as are nursing homes. I'm in Pasadena, and Pasadena has a very high number of nursing homes. The first part of the pandemic in April and May was devastating in Pasadena because we had many, many patients that were elderly that became infected when the virus just sort of ravaged through the nursing homes. That's less problematic now because we have some better PPE and better infection control. But that's why we've been so worried about dormitories. They are a perfect area for viral transmission, and it's very hard to create a situation that isn't high risk for this particular virus. It likes to be in crowds. The duration of exposure I mentioned as to the inoculum of exposure, so the amount of virus you're exposed to and how long you're exposed to it. The host also has obviously risk factors for transmission. We do know that very young children, although they can get coronavirus, less than 5, they tend not to be as sick. This is because their immune systems are not very mature. So that's one part of things. The other is that they don't have a very high number of ACE2 receptors. Remember, that's the receptor site that the virus attaches to. Your number of ACE2 receptors increases as you get older. It also increases with things like smoking and lung disease. And so we do know that those are risk factors for a bad outcome with coronavirus. Occupation is a very high, can be a very high risk situation. Obviously, first responders, paramedics, and fire people, physicians, nurses, respiratory therapists, grocers, bus drivers, taxi drivers, and perhaps things like teachers. We're seeing that now with some of the schools that have opened up where students where the virus has gotten loose in a school, and many of the teachers have become infected. So that's a big concern, obviously, in academic settings. A socioeconomic status. This virus likes to go into populations that really have are of lower socioeconomic status only because they often live in congregate living situations, or they have jobs that they can't stay and do at home. There's nothing to suggest that there are racial disparities in terms of genetics, although we are looking at that, but there's certainly a lot of evidence to show that a lot of this really has to do with more social economic situations. Again, crowded living situations, perhaps poor access to health care, fear of not going to work, that you might lose your job, or your immigration status might be questioned. And so it really has been a very difficult situation for persons of color and lower socioeconomic status for that reason. And it's an area that we really need to focus on. They're a very vulnerable population where we need to really address a lot of the inequities that have happened with this. Comorbidities such as diabetes, hypertension, pulmonary disease, cardiac disease, immune suppressive diseases, all also make your risk when you encounter coronavirus higher then you may go on to develop the disease. So how do we reduce transmission? Well, the first thing is to be far apart. Just sort of imagine it like fleas on a dog. If the dogs are too far apart, the fleas can't jump from one dog to another. Now, one of my veterinary friends informed me that our dogs are terminal hosts for fleas, so that kind of destroyed my little analogy. But the bottom line is that if you stay away from people at least 6 feet, the likelihood that you're going to have, even in an unexposed or unprotected situation if you're not wearing masks, is much less. And that's why this sort of 6 feet mantra is being touted as a safer situation. Obviously, if the wind is blowing or you're in a closed space and there's ventilatory issues and somebody's coughing or you're standing next to somebody who's coughing, then transmission could potentially occur, but it's much less likely to the farther apart you are. So social distancing is a really important part of reducing transmission. The most and simplest way to prevent transmission of coronavirus and prevent infection is masking. And it's a very, very simple procedure. You have to have 2 ears, of course, but it is a very simple procedure that really reduces transmission, and I'll show you some of the data on that. Hand hygiene is very important. Gloves, gowns, and personal respiratory equipment are used by first responders and healthcare workers. But for all of us, masking makes an enormous difference. And we can see that each time we sort of open up society and people don't wear masks, we have a huge outbreak of disease. People get scared, they start being better about wearing their masks, and all of a sudden the disease goes down. So it is a very inexpensive, highly effective way of preventing transmission of a respiratory pathogen. And I can't emphasize enough the importance of wearing a mask. There are, of course, 3 different types of respiratory protection. There are surgical masks or cloth masks. I'm going to show you a little bit more about that in a second. We have special masks called N95 masks. Those have a very, very fine mesh so that they can basically prevent transmission of even viruses, very high micropore levels. And then finally, a personal protective equipment, a PAPR. These are used by our intensivists and our nurses in the ICU. Those are self-contained systems that allow you to go in for long periods of time to work with patients and not get too hot or have trouble breathing yourself. This was a study that's a pre-auth study that was put in Science that basically looked at some of the data, and it shows that masks certainly decrease and reduce the airborne transmission of this particular virus. You can see in the first diagram someone who's speaking who's unmasked, and they have rather extensive particles posing a threat to a person. The unmasked person standing next to the other person is at maximum exposure. If one of those people or both people are masked, then that really reduces the exposure. So wearing a mask not only protects you, but it also protects the people around you. And it's a great way to say, I care about you as much as you care about me, and I'm going to protect you by wearing a mask. So again, this is just confirmatory scientific data. This was a study that looked at, did epidemiologic data, and it looked at counties where there was a mandate for wearing masks. And those counties had substantially less incidence of coronavirus. And indeed, it was a mathematical modeling paper, showed that by masking people, it prevented probably hundreds of thousands of cases of COVID. So we know that it works. We know it's very effective. It's a very inexpensive thing to do. And again, there's scientific evidence to show its benefit. And then finally, this was a little paper that came out last week that was kind of interesting. They took a whole bunch of different kinds of masks. You may have seen this in the New York Times. And they did a very simple laser-guided droplet test where they had people talk into a machine. And you can see that the highest droplets, of course, are in the green where there was no masking. N95s have the highest resistance in terms of passing viruses on or droplets on. But you can see that even cloth masks are pretty effective at preventing viral transmission. So we do recommend that you wear a good mask that has fits properly. You have to wear it over your nose, not under your nose. that doesn't do anything. But even a good cloth mask can really provide you with quite good protection. Knitted masks, gauze masks are not very effective. And what was interesting that came out of the study was the potentially increased risk that you have by wearing a bandana or one of the scarves that you pull up over your head. Apparently that can actually allow the virus to get create microparticles, and it can actually increase your risk for getting infected. So in terms of viral transmission, some of these fleece and bandana type masking things are not very good. So I would recommend just a good solid cloth mask that protects you, or if you're a healthcare worker, then obviously wearing surgical masks or an N95 in very high risk situations. Hand hygiene, because of the potential for contact transmission, is always important. At Huntington Hospital where I work, we used to always have to get after doctors. Doctors are the worst at washing their hands, but boy, we went from having about a 35% hand washing compliance to about a 99% hand washing compliance right now. So it just takes a really nasty pandemic to get doctors to wash their hands. But this is clearly a way of preventing disease. Wiping down surfaces after you've used it is a good idea with bleach or alcohol, and it's a very effective way of preventing transmission. This was a study that was published a little bit earlier in New England Journal that looked at the risk of packages and contact material. And although the study did seem to show that the virus could be isolated from cardboard and plastic and so forth, the infectivity of that, again, is not very clear. And a lot of people still feel comfortable wiping down their Amazon packages carefully and then destroying the cardboard, taking the contents out very carefully. Again, the vast majority of people get this virus from someone else, not from a package. But if that makes you feel better and decreases your anxiety, that's fine. It's not a particularly common way of transmission. Now, in the hospital, telephones and computers and areas where there's a high density of COVID around and you have people walking in and out of rooms where patients have coronavirus, that's a different story. And again, we wipe down all those surfaces regularly. Alcohol works very well, as do bleach-containing substances. It kills the virus very quickly. And so those are very effective ways of preventing contact transmission. The other way to decrease transmission is if you're sick, to stay home. And then we can't encourage that enough in people to not go to work when you're feeling sick. And right now, if you have the sniffles, a little fever, achy bones, that's not the time to go to work. You need to call your employer and tell them because those can be some of the manifestations, the early signs of coronavirus infection. We know that outdoors is safer than indoors, and they certainly recognized this back during the 1918 pandemic, where they held a lot of classes outside. These are kids in New York during the winter time, I think, having a class outside. Occidental is prepared to do that if we need to in the spring quarter. They've set up some very nice outdoor venues to do classes in. We're lucky in Southern California we can do that. So that's a much safer way of doing lectures, although you can see still a little bit being too close together is not a good idea. So what does this virus look like? Well, there are 4 major proteins, and I'm not going to spend too much time on this, but the spike protein, of course, is the most important protein, and that is what allows the virus to attach to human cells. It does have some other proteins that might be important in developing a vaccine, but most of our vaccine development right now is focused on the spike protein because that's such an essential part of SARS-CoV-2. And it allows attachment to the host and then subsequent fusion of the virus into the host cell, which then carries on, allowing the virus to replicate and produce more viral particles. So when it does that, this was a nice little set of cartoons that was in the New York Times quite a while ago. You can imagine it attaches at the ACE2 receptor site. It then sort of squirts its genetic material into the cell and turns the cell through a part of the cell's own machinery, something called the endoplasmic reticulum, into a viral factory. And this starts making more and more virus. The cell then dies, releasing more virus. And this happens, tens and tens and tens of billions of particles, allowing the virus to spread very, very quickly. Somebody who gets COVID and is sick, that happens in a very, very short period of time, and I'll show you that in a second. In addition, the release of those viral particles stimulates the immune system, and we know that part of the really bad parts of COVID-19, the disease caused by SARS-CoV-2, is this over-exuberant inflammatory response that happens in the body. It's an inappropriate response to a large degree, and that leads to a lot of the respiratory problems and often, I'm sorry to say, death in patients with COVID-19. Again, the endoplasmic reticulum is a normal part for those of you going into biology. For the students, this is, you'll remember this, or you're going to learn a lot about this. This is part of a normal cell, but the virus takes it hostage and basically turns it into a viral factory. And then it produces this really severe immune response where you have activation of the immune system, a dysregulation of the immune system, very high levels of circulating inflammatory chemicals, a profound reduction in cells that help you fight off infection, infiltration of cells and virus into multiple organs, especially respiratory organs, but other organs as well. A lot of activation of other cells in parts of the immune system, and clot formation. All of those lead to a lot of the what we call pathophysiology of the disease. So again, it's this inflammatory storm that happens from a release of all these really nasty chemicals because it just sort of ramps up the immune system to react inappropriately. Now, not everybody has this response. Many people are asymptomatic. They never get the disease. Many people have a very normal immune response and it takes care of the disease. But this is the part of the disease that leads to people being hospitalized and very sick. And one of the more dramatic manifestations of post-coronavirus infection is this pediatric hyperinflammatory syndrome, which you've probably heard about on the news. Children in general don't get as sick with this disease, but we are seeing now this disease more commonly in children who've actually recovered from COVID-19, and then they have a post-infectious inflammatory syndrome that can be very, very serious and sometimes lethal. I want to just briefly mention T cells. I'm an HIV specialist, and T cells are a very important cell line, obviously in HIV, but they are becoming increasingly important in COVID-19 as well, because they are part of what we call the adaptive immune system. That's the part of the immune system that remembers having been exposed to a certain virus. And that may be a very key element in developing a vaccine, and I'll briefly talk about that in just a minute. So the risk factors we talked a little bit about for acquiring the disease, and when you sort of put those together, other things such as gender, we know that men tend to, when they get the disease, don't do as well as women. It's not clear why that is. It probably doesn't have anything to do with estrogen, because postmenopausal women still have an advantage. It may be the presence of 2 X chromosomes that allow women to have a little bit more normal immune response. But about 60% to 40% of men, 60% of men as opposed to 40% of women have a higher mortality, and that's been borne out in most studies. This is sort of a classic CT scan of someone with COVID-19 pneumonia. They get this kind of peripheral inflammation, all the white that you see on the edges of the lungs, and the lungs basically just fill up and they become very, very short of breath and hypoxic and eventually have to be put on a ventilator. But there are other organ systems that are affected besides the lungs, the heart, kidneys, brain. We know that there's an encephalopathy or even an encephalitis associated with COVID. The immune system we mentioned. Coagulation systems are a really important part of the pathophysiology of this disease, and so we do use anticoagulants to try to keep that under control. Reproductive, more in the sense that the testes in particular may be a sanctuary for virus, and that may also be why men tend to do a little bit less well than women. This is a lung that was removed from a 29-year-old patient in Chicago. She had very bad COVID and she required a lung transplant. And you can see the terrible damage in a very short period of time. She was a normal 29-year-old 3 weeks or 4 weeks before she became sick, and this was the end result. So in a very quick amount of time, her lungs have become scarred and fibrotic and are not very good at oxygenation. This is an outline of the pattern of infection and symptomatology. If you get exposed at time 0, usually the onset of symptoms occurs within about 5 to 10 days or so. That can vary a little bit. Some people don't manifest symptoms ever. Some people manifest symptoms sooner, but usually 3 to 5 to 7 days is about when you start feeling having symptoms. And that's also when some of your immune system begins to start producing antibodies to the virus. Many people begin to improve after about 14 to 21 days, and that's why we pick those numbers for quarantine, that if you're exposed, usually by day 14, you'll have either symptoms or you won't have the disease, and then you can come out of quarantine. So that's why that number is used. These numbers are also important in terms of following the development of immunity and the emergence of neutralizing antibodies, which are a very important part of your response to COVID. So we'll talk about that in a second when it comes to therapies. Testing has been the biggest challenge in the United States. It really has been a conundrum in terms of our ability to get on top of this disease. And we've had bad testing, we've had not enough supplies, we haven't been able to test even in hospitals. It's very problematic. And then these terrible wait times where people get a test and the test results come back 14 days later, which is absolutely of no utility at that point. So this really has been our weak spot and why we've done so much less well than some of the countries in Europe and certainly than countries like Korea and New Zealand. What we need for testing is to have an ability to control the pandemic and to assess the disease density and that's what testing is for. It needs to be highly accurate. We need to have plenty of supplies. It needs to be inexpensive and it should not pose any transmission risk to the collector and we should get very fast results. What we have are many different companies making tests. Some of them are accurate, some of them aren't. The availability is still problematic. It does require some skill to do the test properly, and the collectors usually have to wear personal protective equipment, and now the turnaround time is often delayed. So those are all the problems that we have that we're dealing with right now. There are two types of testing: molecular testing, which tests for the actual virus, and for active infection. That's a PCR test. It's a very good test. It has good specificity. In other words, it's likely to detect disease in its presence and also to be negative if you don't have the disease. But it's the most expensive kind of testing, and it takes a while for it to be processed, and it can be somewhat problematic in terms of the collection. There are less expensive molecular tests. So there's something called an EIA antigen tests. Those are very rapid tests, but they aren't nearly as accurate. You may have heard about Governor DeWine. The president was coming to visit a couple days ago, and he had an antigen test that was positive. He was later tested twice with a PCR test that was negative. So that test was a false positive. So antigen tests, though they are rapid and can be used sometimes in screening situations, are not nearly as accurate as PCR testing. Serologic tests test for the presence of antibodies. That's after you've had the disease and are recovering. They are of no utility in identifying people who are acutely infectious, but they are helpful to see if you've been exposed to the virus and might have some immunity. And this is just a typical PCR test. This is the test that we use in the hospital where I work. The turnaround time for this test is 2.5 hours. It's very good, but it's also in short supply now. And it is a test that we do use in our critically ill patients when we need to place them in the hospital appropriately. ARUP and some of the other big testing platforms have antibody testing. Again, it's being used more as an analysis of how the virus is spreading in the community and looking backwards, but it really is of no utility for acute management of the disease. During pandemics, you have to be very careful that you don't fall victim to sort of the snake oil salesman. And so it's very important. In pandemics, there's a very big pressure and when in emergencies like this to provide therapy for people that may or may not be proven. It's sort of desperate times require desperate measures. But you still have to try to practice evidence-based medicine and to do good science. You don't want to look back and go, we shouldn't have given that drug to those people because it may have caused them harm rather than help them. So that's something to really keep in mind. I train young physicians and I really try to tell them that everything has to be evidence-based. Even during a pandemic, you have to keep your standards up so that you maintain a good level of care for patients. We know that supplemental oxygen is helpful for these patients that are presenting to the hospital. We do something called proning where we have them lay on their bellies. That increases and sort of recruits more cells, more aeration for them and improves their oxygenation. We have learned now in the last few months that we probably want to try to keep them off a ventilator as long as possible. And so in the early part of the pandemic, often the intensivists would intubate people, put them on a ventilator very quickly. Now we're delaying that as much as we possibly can with different kinds of techniques. And so that's something that we've learned in terms of ventilatory support. In terms of therapies, we really don't have any game changers right now. The drug that you hear about is an antiviral called remdesivir. It was originally designed for Ebola. It didn't work very well with Ebola, but it was tried with the first SARS and seems to have activity against SARS-1. And so it has been sort of resurrected. I use it quite a bit. It does diminish the number of days that people are in hospitals, and it probably its utility is better in people who have mild disease, but it still is, again, many patients go on to die in spite of using this drug. It's relatively safe and it has been well studied. There are some other antivirals that have been looked at. Again, the history with HIV will give us at least a leg up in terms of developing future antivirals for this disease. One such one is called EIDD-2108. It's an oral medication. It's been studied pretty heavily in animals. It's yet to come into human trials yet. But the advantage is it's the oral. It can be given to people who are infected with SARS-CoV-2, and it may prevent infections. So that's something to keep an eye on as we move forward. We desperately need a drug like Tamiflu, which we use for influenza, that we can give to attenuate the disease, if not prevent it. We have medications. You may have heard about the dexamethasone use. That's an anti-inflammatory to decrease the inflammatory storm that we see with COVID. That also is not a game changer, but it does seem to help, and we do use that. And then finally, convalescent antibodies are antibodies harvested from someone who's had HIV, who's had coronavirus, and then we use them to try to protect patients that are treated, that are actually infected. So the antivirals, the mechanism of action is mostly at the spike protein. We want to interrupt viral replication, and also we can have a possibility of interrupting post-viral production. Those are all potential sites for developing antivirals. Again, these patients tend to have blood clots, so we want to use blood thinners, anticoagulation, to try to reduce that, but that's not without risk, so we have to be very careful. And then this is just remdesivir. It's given only intravenously. It has now become a scarce commodity, so we have to use it very carefully, only in people who are likely to benefit from it. This was the data that was presented in New England Journal. Again, it's not a game changer. It doesn't get people to dance out the door, but it may decrease their length of time in the hospital. And so that's why it's such an important antiviral. EIDD, I already mentioned. This is the study for dexamethasone. It was a study done in the United Kingdom, and it again showed its role in treating critically ill patients. But again, for milder disease, we don't think it has any effect. Neutralizing antibodies, we know that in monkeys that are infected with SARS-CoV-2, if you re-challenge them with infection, they don't get it. So that's important for two reasons. One is they developed neutralizing antibodies, which have being used now for therapy. And it also is data that we use to help support the use of a vaccine. So we know that infection may protect you. How long it protects you, we don't know, and that's going to be a very important factor. This is some data that's preprint data that's come out that shows that neutralizing antibodies to SARS-CoV-2 do seem to disappear probably after about 75 to 100 days. That's bad news for a vaccine because you don't want to have to revaccinate people every 3 or 4 months. But what may happen is that your cellular immune system, remember the T cells that I mentioned before, may take over and cause other cells called B cells to create new neutralizing antibodies. So we're hoping that's what's going to happen with vaccine development. A company called Regeneron is looking at monoclonal antibodies. This trial has just started. UCLA is a participant. And it's basically giving people neutralizing antibodies, not convalescent plasma antibodies, but neutralizing antibodies that have been made from genetic engineering. And this may be useful not only in treatment, especially early treatment, but also protecting first responders and healthcare workers when they're dealing with high levels of coronavirus. A convalescent plasma is, again, plasma that's been harvested from people who have had the disease. You probably have heard about Tom Hanks. He's made multiple donations. We use it a lot. I've used it many times. Again, it's not a game changer. It does seem to help people, especially if you catch them fairly early. And it's a safe therapy. It's not very risky, but it's also a scarce commodity and isn't something that's going to make a huge difference in their outcome. And there's other medications we've been looking at, and other kinds of anti-inflammatory medications. I want to briefly mention hydroxychloroquine because it's sort of been the bane of everybody's existence here. Very good clinical data now that shows that it doesn't work and it does pose a significant risk to people. So we really, it's been taken off of all formularies in hospitals to use it, and it is really not a good medication for this particular disease. A very interesting study that came out of Scripps down in San Diego that looked at serum that was collected in 2017, 2018, and then put in the presence of SARS-CoV-2. This was serum from people that had other kinds of colds, and it seems like they actually may have had some pre-existing immunity to this. And so that might account for some of the disparity that we see with this disease, where some people get really sick, other people don't get sick at all, or only have a mild disease. There may be some cross-reactivity with other coronaviruses that lend some immunity to this particular pathogen. It's not very good immunity because this disease is so widespread, obviously, and it's a very dangerous disease, but it is an interesting observation and will probably need to be looked at more seriously. In patients who have recovered from COVID, we encourage them to make a donation of plasma. I think many of my patients that's the first thing they ask about. It makes them feel better that they contribute or give back after they've benefited from this. We don't know what the long-term sequelae are of this disease. There may be many clinical manifestations, perhaps ongoing pulmonary and cardiac disease. There's probably going to be psychological disease. I think nobody's had time at this point to sort of develop PTSD, much less address the terrible situations that we've had to deal with both as providers and also for the patients. And the final question is, can patients get a second infection? We don't think so. There was some early concern about this. That turned out to be probably just people that continued to express virus but really didn't have a second infection. But that is something of concern, and we're going to have to watch that going forward. So finally, I just want to talk a little bit about vaccines because this is perhaps our way out of this pandemic. Again, this was monkey data that was done quite early that showed that a DNA vaccine given to rhesus macaques who were then exposed to SARS-CoV-2 did not acquire the disease, or if they did, it was a very attenuated disease. So in theory, this is proof of concept that we have that a vaccine can work, at least in animal studies. With that information, the Operation Warp Speed, which is the federal funded project to find a vaccine, has been pouring billions of dollars into many companies to try to find a vaccine. And right now there are about 4 to 5 that are in what we call phase 3 trials, where they're recruiting 30,000 individuals. You've probably heard about the Moderna vaccine. That is in phase 3. That is an mRNA vaccine. That's a different kind of vaccine. I will tell you that no mRNA vaccines have been brought to market prior to this pandemic. That doesn't mean that they won't work. They do have some advantages in that they appear to be safe, and they also are very easy to ramp up in terms of production. So that may be an advantage. We'll have to see how they play out. That's a 2-set vaccine, and they did have rather serious side effects. I'll show you that in a second. Oxford University in England is using a more conventional vaccine platform. They've been paired up with AstraZeneca and produced a chimp adenovirus vaccine. Their data looks very good. I'll present that to you briefly because they looked at not only neutralizing antibody response to vaccines, the good antibodies that we want to create, but also T cells. Remember the T cells that stimulate the immune system. Novavax is a new company. You may have seen this on the news. They have some nanotechnology that they're using. They're also entering phase 3 trials. Again, no nanotechnology vaccines have been brought to market yet. That doesn't mean it couldn't happen. It's just might be a little bit bigger lift. Sanofi, GlaxoSmithKline are producing a more conventional recombinant vaccine. And then Pfizer also is coming out with an mRNA vaccine. So many vaccine companies, there's about 150 vaccine companies that are looking at things. These are the big ones and probably the ones to watch. I think it's entirely possible we may have some very early data about the efficacy of these vaccines, perhaps as early as the end of October and November, but I don't think that any of these vaccines are going to be up and running if they work until probably January, February, and maybe later. This is the Moderna vaccine, in which you can see that these achieved very high levels of neutralizing antibodies. They never showed the data on the lymphocytes, so I can't speak to that. These were 3 different doses of vaccines. At the very highest dose, 250 micrograms, people got pretty sick. And the company listed these as kind of mild to moderate side effects, but I don't know, a fever of 103 doesn't seem like a mild side effect to me. There was injection site pain, and one poor fellow passed out. So not without some effects, but over the long haul, probably pretty safe. This is the AstraZeneca data, and basically what this showed was a good response with convalescent antibodies, probably higher, frankly, than even people who had natural infection. But more importantly, on the right side of the slide, activation of the T lymphocytes, which again are the adaptive part of the immune system to stimulate more antibodies to the virus, and that's really probably the more important piece for immunity. I wanted to finally mention something about SARS-CoV-2 hyperimmune globulin. This is something that hasn't had too much funding, but actually is a very interesting, very old type of therapy. We know it works because it's worked with hepatitis A and measles. Obviously with rabies, we give hyperimmune globulin for rabies infections. It would be easy to do. It could provide pre-exposure prophylaxis for healthcare workers or first responders. perhaps post-exposure prophylaxis for people who've been exposed to the disease but don't yet have it. And there might be some utility in using it in early treatment. It's gotten some attention recently and may get some more funding, so that's something to keep an eye on and could be something kind of as a transition or bridge to a vaccine. So until that happens, what can we do? We can practice social distancing, which I mentioned. I would really avoid non-essential travel. I know it's the summertime, everybody wants to take a trip. Airplanes are still very high-risk areas. You have to go through the airport, you're really exposed to lots of people in those places, and somehow having an empty seat between you and the person next to you doesn't make me feel any better, no matter how many people are wearing masks on the plane. So it is a high-risk activity, and you really want to think twice if it isn't something that's an essential travel. But when you're not traveling, try to stay away, stay far away from certainly strangers and limit gatherings so that you don't spread the disease. About 3 weeks into the shelter-in-place order in California, my mother was looking through one of her boxes and she found this picture. And this picture was taken by my grandmother in San Francisco in 1918 during their pandemic. And what they were trying to advertise then is just as true now, that wearing a mask may save your life. And so very old-fashioned modalities can sometimes be the most important way of protecting society and protecting individuals. So I would encourage people, again, to really pay attention to mask wearing. It's the safest thing that you can do. So what's going to happen going forward? Well, hopefully it won't be apocalyptic, but this is a big challenge. This is a brand new pathogen. It happened very quickly. It's spread all over the world. None of us have any immunity to it. It's highly infectious, and it's going to be a real big challenge to get this under control. To open up society and schools, you have to have adequate testing. And I think you can see when you don't have good testing, lots of people who are not aware they have the disease can spread it. And so it's a really essential part to doing things safely. We want to try to make decisions based on science, and we want to educate the public about this disease so that they can make good decisions themselves. This disease, of course, is having enormous economic factors that will probably continue for many years after we get control of the pandemic. And recovery may be delayed because of it. And not just in this country, countries, I worked in Tanzania, countries like that are very fragile, so something like this can absolutely devastate them and cause many kind of collateral damage with other kinds of factors, including other diseases like tuberculosis and HIV. We have to address vulnerable populations, our elderly, our people that are on the front lines, our lower socioeconomic population, our patients with comorbidities and other kinds of diseases. Those are the people that really suffer the most with this disease, and that issue has to be addressed. We have to perhaps change how we deliver healthcare. We certainly have to have access to healthcare for everyone and provide good care during pandemics like this. We have to have the technologies to do that. And I think that the good thing that came out of the HIV pandemic was our knowledge about viruses, our ability to develop antivirals that were very effective and to get control of that disease. It took a long time to do it. Hopefully we can work a little faster with this disease, but it has been very successful. We may have to change how we plan cities and how we provide transportation, where we're not crowding people in, where viruses can spread very quickly. Technology, again, whether it's testing, whether it's developing vaccines, whether it's delivering healthcare, whether it's how we communicate. Obviously this was the time to invest in Zoom. So I think that that really are going to be lasting effects. And we finally have to address things like climate change and prepare for future pandemics and again, address social equality. It's very common for for pandemics to stir up a lot of social inequities that happened during the HIV pandemic in 1982, 1981, and certainly with this virus, we've seen it again. And so it's very common for that to happen. We need to address it, we need to recognize it, and make changes that are appropriate going forward. With that, I try to end on a hopeful note that I think we can get over this hump, but it's going to be a bit longer. Just hang in there. You've got to wear your mask, practice social distancing, wash your hands, be patient, pay attention to science, and we will get through it. Those are my references, and I'm ready to take any questions if you have them.
Hi all. So I actually have to jump off for another meeting. So Monica is going to do the question and answer. If you have any questions for me regarding what Oxy is doing and the work at Emmons, I tried to answer as many questions as I could in the Q&A. So Monica will follow these, and you can feel free to email me at Semal, S-E-M-A-L @oxy.edu, and I'd be happy to email you my response or jump on a phone call and share with you a little bit about the work that Oxy is doing to prepare for the fall and the spring. Thank you so much. Thank you, Kim.
Thanks, Sarah.
Hi, everyone. So I know that we are about 5 minutes past 5, but Kim has agreed to hang on for a few more minutes. We have about 8 questions in the queue, and this is being recorded. So if you have to dial off, please don't worry, you can catch up with this portion later. But one question that came in, Kim, is have there been studies around early treatments utilizing protein blockers similar to some cancer treatments? And is that what the vaccine research is based on?
Well, there may be some. Right now, the vaccine research is really looking more at stimulating the immune system for immunity. They're certainly blocking the attachment of the spike protein. Might be an area where antivirals can be developed. The use of other kinds of medications, such as the biologic agents that we use in cancer chemotherapy, may have some efficacy. Some of those have been looked at. A lot of those medications, as they exist, have quite a bit of toxicity, so you have to be very careful. These are very, very sick patients that you're dealing with at the hospital. We are looking at anti-inflammatory medications quite extensively. Again, those are problematic. So far, the data with those drugs are not very helpful. Blocking viral proteins is certainly a very intense area of focus. A lot of the funding right now is really focused on vaccine development because that's going to sort of give us the biggest bang for the buck. But I do think that developing effective antivirals and looking at early interventions are going to be very, very important. And that's perhaps where the monoclonal antibody therapy may come in as well. So yes, it's being looked at. We don't have anything right now that we can use, but it is an area of study.
Okay, thanks. Sticking with kind of antibodies and vaccines, David Ho's research at Columbia has found specific antibodies in recovered patients that are highly potent at turning back the SARS virus. Do you know the status of these neutralizing antibodies moving into clinical trial?
Yes, I mean, I think that again, this is going to be a focus that, Dr. Ho has, a very impressive credentials. He's a big HIV researcher. The presence of neutralizing antibodies is a very important part of natural immunity to this disease. The monkey data, again, supports the use of it as a potential therapy, and that's what's sort of been driving Regeneron in their development of monoclonal antibodies. I will tell you that 31 years into the HIV pandemic, we still don't have a vaccine for HIV. And you can measure very high levels of neutralizing antibodies in HIV, and it doesn't appear to be protective. So the bad news is there is a possibility that these vaccines will not be effective in preventing the disease. But I do think that neutralizing antibodies are the focus right now in terms of vaccine development and/or therapies. And Dr. Ho is a very reliable researcher, so we'll see what he comes up with.
Wonderful, thank you. Any comments on the role of zinc in COVID treatment?
We do use zinc. Zinc's been looked at, zinc is sort of the common cold treatment. It does seem to have a little bit of activity against coronavirus. There's about 2,000 or 3,000 things that if you put coronavirus in a petri dish with, it'll kill it. But the problem is it doesn't work in humans, or if it does work in humans, it's really toxic. Zinc, thiamine, vitamin D have all been looked at. Most of them are not game changers. We do use them in patients. Those are harmless therapies. Again, in a pandemic where you're trying to find something that might help a little bit, as long as it doesn't hurt a patient, then it can be used. But we need to be very careful with some of the other vitamins. People can accumulate vitamins, and it can be toxic if you take too much vitamin D. It is something to look at. I don't think the vitamin therapy is going to be the way out of this, but zinc does have some efficacy in terms of its antiviral effect.
So we have a couple more questions I want to ask, and please know that if we don't get to your question, I will send those to Kim and to Sara afterwards so that they can possibly address them offline. But historically, the safety monitoring period for vaccines has been over 3 years. We're obviously fast tracking a lot of things. So we had several questions come in about how soon do you think vaccines will be generally available? How safe would you think a vaccine would be if it does become available in, say, early 2021?
Well, I think that is a huge question, and that's going to be a very critical question. I think that to get vaccines made for a novel virus and to get them into phase 3 trials in basically 5 months is a huge accomplishment. However, we do want to take a moment and take a breath and make sure that we're doing things properly and that the vaccine doesn't seem to have any kind of harmful effects. And so that we're taking some risks here by mobilizing things so quickly. Most of these companies have been instructed to go ahead and start making vaccine so that if any one of them, there may be multiple vaccines that prove to be effective, that they can be started, that they already have a backlog so we can start administering it. And there is always a concern. It's one thing if you test 100 people, even if you test 30,000 people, and you don't seem to see too many deleterious effects. When you start testing 30 million people or giving a medication to 30 million people, you may see some things that you didn't see in the smaller group. So those are all concerns. And there is a lot of pressure on the FDA and on, frankly, WHO to maintain that the vaccines that are eventually utilized are indeed safe. We do have some good background with this in terms of, influenza vaccines now are very, very safe and effective vaccines. By the way, everybody should get a flu shot this year. We know that vaccines for HPV or for the Zostavax, or not the Zostavax, the Shingrix, the herpes zoster vaccines are very safe. So we have a little more experience with vaccines, and certainly this pandemic is going to make us more learned about using vaccines, but that's a big problem. I think that, again, as I said, they may be able to peek at some of the data from these phase 3 trials by the end of November and recognize that they're effective. These are trials where 15,000 people are getting the vaccine, 15,000 people are getting placebo. And the Moderna vaccine was started in Georgia. They have a high density of disease down there, so it's possible that we may see some early effectiveness in the group that got the vaccine. How long that immunity lasts, though, is another really critical question. If it doesn't last more than 6 months, we're kind of back in the soup because it's going to be hard to do something that frequently.
Thank you. And I'll close with this question. So if someone gets COVID-19, gets coronavirus, and they're sick at home, are there any over-the-counter medications that you recommend to reduce symptoms? Can any of those medications potentially reduce the risk of hospitalization? Any advice that you have for people who do find that they have it?
Well, again, the vast majority, about 75%, maybe 80%, and certainly depending on your age, maybe 90% of people who get this disease are really sick with it or may only be mildly sick and get over it. So most people recover. My world is the world of people who are hospitalized, and so that's a very different perspective on COVID-19, and you have to have a lot of respect for this pathogen. It kills people really, really quickly. But over-the-counter stuff, I would stick with sort of the usual things. I would prefer Tylenol over Advil, not so much because Advil increases your risk of viral problems, but it can cause problems in your stomach, and so Tylenol is probably a more effective medication for fevers and myalgias, body aches, and so forth. If you want to take some zinc, it's probably not going to hurt you. Don't take a lot of it. I wouldn't take more than whatever the dosage is on the package that you have. Vitamin D might be reasonable. Again, a fairly safe vitamin. Whether it provides any efficacy in early disease, we don't know. But if you have loss of sense of taste and smell, which is often an early sign, taking some vitamin D and some zinc and some Tylenol might not be a bad idea. There really isn't any therapy at this point that we can give you as an outpatient that will, dramatically prevent, progression. But we do want you to stay home and rest. You don't want to give this to other people. We've had a few families where we had one family a few weeks ago that the son came home. It was Father's Day. They had a big celebration. The father got COVID and he passed away. And that's a terrible legacy for a kid to have to live with. And so remember that if you have this infection, it's highly infectious. Please stay home. You have to self-isolate from your family. Most people will get through it and get over it just with simple kind of over-the-counter remedies, like I mentioned, and don't spread it to other people if you can prevent it.
Kim, thank you so much. We really, really appreciate your time today. I know I was anxious to see this presentation. I'm sure many alumni, parents, community members were as well. And thank you so much for the work that you've done in helping to prepare Oxy for whatever may come, for being prepared for students to return, for having faculty and staff work safely on campus now, and for protecting everyone. So we really appreciate your time. For those of you still on the call, this was recorded. Give us a couple of days, please, to get everything converted and to get that posted online. And then we'll send out a link, a copy of the link to everyone who attended, as well as those who registered and weren't able to make it or had to dial off early. We'll also send out a copy of that link in the next copy of the e-newsletters for parents and alumni. Thank you everyone for attending, and please stay safe and follow all of Kim's good advice.
Thanks so much, Monica.
Thank you.